Hello and welcome to this lecture. Today we are going to discuss another topic which is asthma, and I'm going to present another case of a 23 years old woman goes to see her general practitioner because she had several episodes of shortness of breath in the past 2 months. The episode lasts up to 30 minutes and are sometimes associated with wheezing. She thinks that there is a connection with being exposed to dust, as she had her worst episode when she was helping to clean a friend loft, and another episode when she was changing the bag on her vacuum cleaner. She also thinks that cats trigger her shortness. In addition, she has noticed that she something have a dry cough, particularly at night. She has not had a productive cough, hemoptysis, or chest pain. She is otherwise fit and well and takes regular exercise, and her exercise tolerance remain unchanged. So we need to discuss the key characteristics of asthma. What is the cause of asthma? Discuss the pathogenesis of asthma. Recall the morphological and clinical features of asthma. So it is defined as a chronic inflammatory disorder caused by the recurrent episode of wheezing, breathlessness, chest tightness, and cough, particularly at night. So if you take a look of my case study, going back to see you, all characteristics are being observed. Number one, wheezing that she has mentioned. She mentioned several episodes of shortness of breath, which is another sign. Then she mentioned that she faced shortness of breath when need to clean the something. So you can see that they are very clear indication of this thing. And then no productive cough, which in chronic bronchitis we have productive cough. So that's a key characteristic or key difference between asthma and chronic bronchitis. And at night, we mentioned at night in the definition. What we see in the in here, they mention, yes, particularly at night, dry cough. So you can see that all key characteristics have been found in the case presentation. The hallmark of asthma is it is intermittent. What is meant by intermittent? It is not continuous. A reversible airway obstruction, it means that the obstruction can be reduced or removed after certain time. Then chronic bronchial inflammation occur with eosinophil. That is very, very important. Why eosinophil is important? Because remember this point, wherever a person is allergic or immune response because of the allergy, the eosinophil count will be increased. And I already discussed this thing before in our previous lectures. Then we have bronchial smooth muscle hypertrophy, hyperreactivity, and increased mucus secretion. So how can you differentiate bronchitis, chronic bronchitis with asthma? Both are increased mucus secretion, but this is more intermittent. The cough will be dry, and then if you take a look of a microscopic characteristic, there will be high eosinophil. So we need to verify and diagnose properly for the patient. Note, asthma has an increase in incidence significantly in the Western world over the past 4 decades. And the reason behind they talk about the hygiene hypothesis, because we want to clean ourselves too much that we are not exposed to the bacteria or viruses that are surrounding, and that's lead to the hypothesis that the researchers now said that especially at a young age, children need to expose some of the microorganisms. How they need to go to playlands, play naturally, play in the mud, exposed to some of the bacteria so that their body get immune to it. So because in the current, I think we can say that 10 to 20 years, we are now more careful of our hygiene. So that's why our immune system have not been developed. And what happened that when suddenly some infection or bacterial infection or allergen or any microorganism affect your immune system, then your immune system is not ready to trigger. So that's the one of the hypotheses. But again, this happened because we can talk about in that scenario. Then pathogenesis, we discussed this pathogenesis in terms of the genetic predisposition. Sometimes it's linked to the genetics, and it could be subclassified into atopic and non-atopic. In both type of episodes, actually bronchospasm may trigger, such as because of the viral infection, respiratory infection, airborne irritants such as smoke or fumes, cold air sometime, or stress or exercise can lead to asthma for short term, for acute asthma. So you can see that these are all the reasons for the pathogenesis of asthma. When we talk about the genetic predisposition, so we found that asthma runs in family, and it is widely associated with a number of genetic variants that increase the risk of asthma. How can we differentiate atopic asthma and non-atopic asthma? The main thing that in atopic asthma, the classical example is type 1 IgE mediated hypersensitivity reaction. We will discuss in detail in our upcoming lectures. Whereas in non-atopic asthma, it occurs where there is no allergic sensation, and usually the skin test result in negative, and usually they run positive in a family history. Uh, they are more associated with respiratory infections due to viruses such as rhinoviruses or para-influenza viruses, or inhalant air pollutants such as sulfur dioxide, ozone, and nitrogen dioxide that trigger that non-atopic asthma. Whereas when we talk about atopic asthma, it usually occur because of the asthmatic attack caused by allergic rhinitis, urticaria, or eczema, and that trigger because of the dust, pollen, or animal dander, or food, or by infection. So there is a difference between atopic asthma and non-atopic asthma, and the etiological factors for atopic asthma and non-atopic asthma is different. So this on the left side is a normal airway, and you can see in the airway asthma, the main thing is that the mucus secretion is high. There will be more number of goblet cells, high mucus secretion, then the formation of the macrophages. Then you can see that the glands in the left side, there are few glands, but there will be increase of the glands. Then marked eosinophils, the most important that I already discussed, that increase of the eosinophils. Then we have neutrophils and lymphocytes also present. And how they trigger asthma, there is a complete process that can be explained. Like for example, initially when a person is exposed to pollen, as we know that this is atopic asthma, the pollen that enter inside, they act like an antigen. They go inside, and they are responsible to activate the T cells, helper to T helper cells. And what happened then with that process is they bind with the beta cells through IgE, and then they are responsible for making antibodies, IgE mediated antibodies, with the help of Fc receptor, IgFc receptor. So what happened that when a pollen enter inside, in simple term, that in easy word, they activate the mast cells and bind with IgE Fc receptor. That's the main important thing. And then what happened after? Then they bind with the, you can see these small pollens, they are showing express here. So they bind with the IgE. So that is why this is atopic hypersensitivity or atopic asthma. Why? Because it is IgE mediated immune response produced with the help of Th2 helper cells, and then they activate interleukin 5, and that interleukin 5 either from the Th2 cells or from the mast cells to produce more eosinophil recruitments, and that is why there will be increased production of eosinophils, and that will be seen in the histopathology. And then with the increase of the eosinophil, what happens? The release of the granules and mediators will occur. So that's the normal process occur. Again, this is another picture how this process occur. This is the antigen. These are the pollens. They cross the mucosal lining, go inside to the vagal afferent nerve, bind with the Fc receptor of IgE. Then that IgE that is bind with the mast cell produce the immune response in the form of producing eosinophils, and that response go through your vagal afferent nerves. Please read the physiology that what is vagal afferent nerve. Vagal afferent nerve actually are those that send the signal towards the brain, whereas vagal afferent nerve, where this is E afferent, and this they send the message back to the smooth muscles, and with the signal that travel because of the production of eosinophils, and then there is an increased vascular permeability and edema. That these are the signals that increase vascular permeability and edema. These are the signals that send the message through vagal afferent nerve, and then in response the brain send the signal through vagal afferent, where it bind to the smooth muscles. What happened then? The response will be occur at late hours. So you can see initially there will be the formation of eosinophil and increased vascular permeability and edema at initial phases in minutes. And then why the late phase occurred? Because the message sent through vagal afferent nerves, and then it take time from brain to send message back to vagal afferent. And in the late phase, what happened that there will be formation of further immune response. And in the late phase, actually, it is more inflammatory in nature, and there will be production of inflammatory mediators such as chemokinins that promote the recruitment of Th2 cells, eosinophils, and other leukocytes, and they amplify the inflammatory reaction. And they amplify the inflammatory reaction initiated by the resident immune cells. So what will happen? There will be the structural changes in the bronchial wall. We can collectively call as airway remodeling, which result in hypertrophy of the bronchial smooth muscles, mucus gland, and increased vascularity, and deposition of the subepithelial collagen, which may occur in as several years before the initiation of symptoms occur. So you can see there will be more mucus secretion in the late phase. You can see that the activation of Th2 cells may produce more vascular leakage, damage of the mucosal lining, hypertrophy of the cells, and then that occur in the late phase. What will be the morphology? The key characteristic in asthma is formation of Cushman spiral. The formation of numerous eosinophils. Then we have Charcot Leyden crystals. Collectively, we can call airway remodeling occur, that include thickening of the airway wall, sub-basement membrane fibrosis, increase submucosal vascularity, increase in size of the submucosal gland and goblet cells, metaplasia of the airways, hypertrophy, or hyperplasia of the bronchial muscles will be the key characteristics. So this is the picture, and you need to see that how that on the, if you take a look of that normal and asthmatic patient, this section is lumen, this is basement membrane. So what happened? This lumen is more open, whereas in asthmatic patient the lumen narrowed. So bronchospasm occur, number one. Then you can see the basement membrane. There will be more thickness of the basement membrane. You can see the basement membrane is more thick. In the normal, basement membrane is very small. These are the smooth muscles. So smooth muscle hypertrophy occur. Smooth muscle hypertrophy occur. So that's the difference between normal and asthmatic patient. Number one, the lumen narrowed, increased thickness of the basement membrane, and number three is smooth muscle hypertrophy. And if you take a look of this picture, actually this is actually is less magnified histopathology of the patient having asthma, and this picture actually is same when we zoom and see the details. So that is why maybe you are unable to see that what are the changes that can be seen here. So I made this picture to elaborate to you. Clinical features consist of severe dyspnea, wheezing due to bronchoconstriction and mucus plugging. Attack lasts from 1 to several hours, and spontaneous, either spontaneous or with therapy. It associated with hypercapnia, acidosis, severe hypoxia. It may be fatal, although in most cases the condition are more disabling and more than lethal, because sometimes it is fatal. It depends upon the severity or the treatment that patient is taking. So thank you so much for today's lecture. Hope to see you again.